that this project is supported by the Office of Minority Health of the United States Department of Health and Human Services. The grant number is STTMP 15110. The contents are those of the authors and do not necessarily present the office views, nor an endorsement by the Office of Minority Health, DHHS, or the United States government. I want to, first of all, give you some groundwork about what the grant was initially started out, and then Angel will take you through the process of how the program was implemented in their community. And so one of the first things that we tried to address in this grant was the purpose of reducing hemoglobin A1C levels in American Indian adults residing in Thurston County who were diagnosed with an A1C greater than 9. The project phases, first we developed a profile specifically leading to the health indicators, and this helped us find the hotspot of where the health issues were. And we implemented community intervention activities using strategies to improve health outcomes. And from this, we will conduct presentations and also publish our results. So the location of where, just to give you a geographical idea of where we were working here, is Thurston County is in the northeastern part of Nebraska. And there are 2 tribes in this particular area, the Winnebago and the Omaha tribe as well. But today we're just going to focus on the work in Winnebago. So the model begins to address the social needs of individuals, and we kind of give you an idea of how the public health model fits into this. And, you know, one of the things about the community health representatives is that we start with the idea of the individual and then lead our way up to the interpersonal issues of a person experiencing health issues. Then we climb up to organization, community, and then the public policy, though we are just concentrating, though, on the individual and the interpersonal needs of the person. So our intervention was used using the Pathways model, and this Pathways model is evidence-based by the Agency of Healthcare Research and Quality's Pathways model. It does focus on at-risk individuals, connecting them to Health and Human Services. We want to avoid duplication of services, keep people from falling through the cracks, integrating social determinants of health, and finding individuals at risk. So these are one of the key functions that the community health representative concentrated their efforts and energy, and it is within this scope that CHRs work with. So in that, once folks are identified, we want to help treat and then measure the outcomes of the intervention. Again, this is just another visual to give you an idea that the intervention starts with the social economic factors that are the cornerstone of helping individuals go through the process of seeking help and accessing to healthcare facilities. And I will let Angel work on explaining the information to you.
Okay, so eligibility and criteria. They needed to be Native American, reside in Thurston County, Nebraska, be at least 18 years of age or older, a diagnosis of diabetes, and their A1C needs to be 9 or greater. So if they met that they're more than welcome to be able to be in our program. We found that patients who meet those criterias, the criteria for coming to the SPI Pathways program, oftentimes come with many barriers, making it challenging to reach them or getting them to agree to talk to us. I think that the first step is to build rapport with them, and we were able to do that. I'm sorry. And the reason why they're kind of lost to follow up and haven't been coming to their appointments, one of the reasons is they're in denial of having such a serious medical condition. They may be angry at the diagnosis. They may have a fatalistic view, formed from seeing loved ones succumb to the complications and comorbidities associated with diabetes. Some may not have updated addresses, contact information, phones, that kind of thing. So it's nice that being a community health worker, we're able to spend time to go out and find in the community where people are, whether they're at the senior center or at an event, or we hear where they work. We're able to track them down and to help to get them messages and get them appointments and try to build relationships to be able to give them care. Another thing that was kind of unique to our area is we didn't have a lot of Wi-Fi or internet access, and some of our patients didn't have cell phone service. So if we wanted to get a hold of them, sometimes we'd have to message them on if they were on Wi-Fi. So we'd have to kind of wait for them to be on a Wi-Fi network to answer our questions or get our messages. So that was something that was a little bit different. Our team always says that patients with high A1Cs seem to be walking around in a cloud, and it makes it hard for them to rationalize and make changes and choices to help better their health. So we're here to help them with those barriers. We're going to talk about our reservation, and in the Winnebago community, I really like this sign here. It says, "Now entering Native America, Winnebago Tribe of Nebraska." And every day when I go to work, I pass that, and it just brings pride in knowing where we are and where we come from. And we're rich in culture, we're rich in family, and we're just proud of it. Another thing that I'd like to talk about too is the population of Winnebago. So the actual population just right in Winnebago is, according to the 2017 census, is 796 people. Our tribal membership was at 2,694. Our population living with type 2 diabetes, on our registry, that it was 710 patients living with diabetes. And those aren't necessarily patients that are living in Winnebago, but they're patients that go to our past Indian Health Service Hospital. And of that, 72 people are living with A1Cs 9 or greater. This is a very alarming statistic because my caseload, the caseload that I'm responsible for, is only reaching about half of them. And because of our location, we see that our tribe does a good job about getting jobs for our people, but the median income is $19,803, and then the mean is $37,000, about $37,734. So food insecurity is an issue too. So a lot of times patients are faced with food insecurity, and we do a good job about helping them with that and helping them find options, and we have different food sovereignty projects like raised gardens, community gardens. We also have, you can see this picture down here, on the lower left-hand side, that's our village market. So our members are encouraged to grow their food, and then they're able to go and sell that, and they're also able to go and buy things. We have local farmers and different people that come in, and we have different freezer meal workshops to help people learn how to cook and help people preserve and do more with the food that they have and make it last and preserve it. So we're going to go on to the next slide here, and that is our CHR training. So this slide is a list of offered and training tools for the CHRs. It's helped to build a proven and evidence-based practice. And I really can't speak for others, but I can speak for what worked for us. And I think that something that really worked well for us is that we were given the opportunity to get lifestyle coaching. We were given the opportunity to become diabetes educators. And then we got to work with a nurse team. So there was a nurse that worked with me, and she mentored, supervised, and then helped me if I had any questions, if I, was thinking, oh no, what should I do, this patient? And we have an amazing team that really, it's not just me out here by myself, it's our whole team that works together. And I was talking to different people, and I said, well, what do you think, when I was asked to do this webinar, what do you think is issues that CHRs are facing? And this really stuck out to me. It was a medical provider that I talked to, and she said that across Indian country, people have a need and a desire to help at any cost. And it's not uncommon to be put in a position due to the need of the community. And across Indian country, CHRs may not have all the support, encouragement, education, and just somebody in their corner telling them that they can do it and helping them if they have a complex case. And they're not able to work at a high capacity in that position. It's been my experience, if you invest time, training, skill building, and education in someone, they're going to be more apt to stay with that program. You're going to create pride in their job and that person. And also, we talked about compensation and the need for a livable, comfortable, competitive, and desirable wage. We need to facilitate the growth and change that we want to see in our program and our community. And it starts with our training of our CHRs, helping them to take pride in their position, the department, and the community that they serve. So these are the pathways that we had. And the diabetes education, medical home, medical adherence, social and cultural needs, and then behavioral health. I'll be honest in saying that at first I didn't see the big picture. I felt that we're already doing this, and I see things differently now. The pathways are a more organized way and a proven way of helping our patients to work through barriers that are impeding their much needed diabetes care. It gives us a way of tracking the patient's encounters and case managements. When a patient presents with some kind of an issue, whether they weren't sure about what medications to take, sometimes it can encompass a few different pathways. And I think that's what's nice, is that a lot of times our patients aren't aware of what the problem really is, or the issue, the barrier that they have. And when we work through these pathways, it helps to build skills for them to be able to work through other pathways, and not just in their diabetes care, but in life too. So here we have our next slide, and it's talking about addressing the barriers to better self-care. So our community is kind of unique because we had some other barriers that weren't addressed within our community. We had, you can see it says medical home pathway, the mistrust of Indian Health Services. So, we were able to gain our self-governance, and that's been an ongoing, daunting task that we were able to set forth. So we were able to make choices and to help put policies and procedures to better help our population. No-show rates. So with our medical home, no-show rates across the board are something that it doesn't matter where you are. Any kind of office will tell you, oh, my no-show rates are up. Patients aren't coming to their appointments. And one thing that we did to help with that is helped our patients to be more organized, whether it was calendars, whether it was setting alarms, whether it was calling, texting, giving rides, that kind of thing. That really helped. Medical adherence pathway. So our medication formulary, when it was in IHS, we didn't have as many tools in our toolbox that we needed to help with our patients. There were only a set amount that patients could work with, and sometimes they wouldn't react well with the patient's systems. And, you know, we see all these commercials and all this new medicine and that kind of thing. We want to be able to give our patients what everyone else is getting. We want to make that available to them. Another thing that we did to help with medical home pathway, in the beginning we had a provider that was here once a month, and now we've made access a lot easier. We were able to have a diabetes clinic, and our nurse practitioner comes weekly, and we all work with her, and we are able to offer more frequency in appointments and access of a healthcare provider too. Another thing is side effects and mistrust with medications. We're very blessed to have CDEs, certified diabetes educators, within our department, and we can always refer to them, or our pharmacy meets with patients. All the pharmacists meet with patients, and they can go over medications and any side effects, concerns, questions that they may have. And patients are encouraged just to let us know if you're having an issue. That way we can get that. We'd rather have it addressed than have you just stop taking your medication. And patients are pretty honest about if they aren't taking their medication or if they are. That way we can better address those issues. Diabetes education. So in an individualized or group setting, we are able to do lifestyle coaching, certified diabetes education. We also have a diabetes self-management education class that goes on a few times a year, and it's really a big deal. So we'll go on to the next one here. You can see that our social and cultural cultural needs pathway, that's getting people help with utilities, homelessness, housing. It's a multitude of things. Behavioral health pathway, we also have a behavioral health program that we can refer to. So in the beginning, we had a struggle to find a fit. In 2014, 2015, we lost Indian Health Services CMS certification. So a lot of our directors and a lot of our teams were competing to help us to obtain self-governance. There was a lot of leadership changes, lack of accountability. People weren't sharing information the way that we probably could have. And the reputation, there was no need for this program, people thought. Whether it was patients, whether it was providers, we felt, you know what, we're already doing this, and we didn't see the value in it, and we had to see that value. That way we can in turn help our patients to see the value. So we're just talking about the multidisciplinary leadership redirection. With our administration, we formed a new entity, and we renamed our hospital, rebranded, and then changed a lot of things within the hospital. Supervision, our director, our past director, was able to take a position with 12 clans, and then we were able to get a RN, BSN, CDE as a director of our diabetes team. And I think that really helped, because then she had home health care and case management expertise, and she was able to mentor us and help us with that. Another thing is, we had, when it was with IHS, we had a lot of medical providers that were coming and going, and they weren't able to build relationships with patients or trust with patients. And the patients were just tired of coming to a new provider and explaining their whole care and getting to know someone else, and then having to see another one and another one. So they just felt like if they needed something, a lot of times they would utilize the ER. So they weren't getting the care that they needed. So, multidisciplinary team transformation of change. My office was originally over at the IHS hospital, and I was able to switch that over. I had a little cubicle that was open. It was not private at all. Patients would come and talk to me, and it was just very small, very cramped, and it was right in front of a waiting room for our behavioral health, so it wasn't a good location. We were able to get access to electronic health records. So I think in the past it wasn't something that was available to the CHRs who had the program before I had it. So that's really helped. Another thing is our team huddles. We share information, we go over care plans. So it's a multifaceted team that's able to help care and be active members of our treatment plan process for the patient. And the patient is the number one advocate for their health. So we try to involve them and see what they would like to do too, along with family and support. Pharmacy, we work well with pharmacy, contract health, merger of our teams. So we had a Winnebago Public Health Department, our WCHS, and our 12 clans. So we all work pretty well together. Another thing that changed is we have CHR meetings, and our CDE nurse, she's able to help mentor the other CHRs, and then I'm invited to that too, so I take part in that. Improving patient engagement. Since we were moved from the 12 Clans Hospital, formerly IHS, we're in the building, Whirling Thunder, it's our wellness center, and it's all encompassing. So patients can just walk up. They don't have to worry about checking in with people. They don't have to worry, they can just either walk in or knock on my door and say, oh, you know what, I'm out of supplies, or I need this, or sometimes they just come just to say hi and see how we're doing. But it's nice because our post office is right there, our fitness center, tribal council, different children's activities, and then our community gym is right there. So it's in a central location also. So one thing that improved the patient engagement and increased the access is the ease of access at Whirling Thunder, like we said before. Also communication. We have a direct line with the patients have a direct line with the SPI CHR. I give them my cell phone number. It's my work number. They can call me morning, noon, and night. If they see me somewhere out in the community, I'll help them out. And if I don't know the questions, or if I don't know the answers to the questions, or I need help, then our nurses are available to us too. They're just a text or a phone call away, and that way people don't have to wait till Monday, or if it's a holiday and their blood sugar is low or blood sugar is high, or they have a question about how many units of insulin to take. That's something that can be addressed right there for them. No appointment needed, just walk on in. And just having social medical connections with people and having that relationship and being able to feel okay with, some people say, oh, I don't mean to bother you. It's not a bother at all. We're all relatives, and I want people to feel comfortable in doing so. So we like to be visible in the community too, and that's really important. Whether it's a parade or our homecoming parade or a pep rally or a health fair, we like to make sure that we're representing our program and we're available to people. So building trust. So that's just building rapport. And I think that in the past, CHRs weren't given that opportunity. Like I was given an opportunity where I can sit down and I can talk with a patient and I don't have, 30 minutes, I got to get going, that kind of thing. I have a chance to be able to exercise with them. I have a chance to be able to have real talk with people. It's a judgment-free zone. Some of our patients struggle with alcoholism, addiction, behavioral health, mental illness, that kind of thing. And they can share that with us in a judgment-free zone, and we can kind of work around that and be able to help them. At each visit, we do a goal, and then we revisit that goal. And we like to set SMART goals with patients, and they're pretty on it. They already know what their goal is going to be. Most of them, at first, they didn't care for that, but now they're like, okay, I beat this goal. I squashed it. I'm going to go to the next one. So that's where you see people blossom and open up, and they're able to utilize those self-care tools that they learned from the pathways. Like we said, clients in the community, the roles of the CHR to build and maintain trust. Transportation is a big thing. So sometimes people will call me and say, oh, I got to have a ride. I need a ride over here. And I see more often, because we're talking about steps and getting your steps in, people are like, I'll just walk down. It's only 2 blocks. Or if the weather's nice, we encourage that too. Or we'll meet them or at their work or their home or whatever they need. Social and emotional support to improve diabetes testing and monitoring. So we'll try to check in and we'll say, hey, what did you eat? Or send me a picture. And that's what's nice about technology now. We're able to, if somebody's sitting down, they can say, oh, I only ate half of this, or I only ate this and that. And we can share that information with our registered dietitian or with our CDE. And then it creates accountability for people too. We help them to identify and overcome barriers. And then also we collect and share data with the Diabetes Task Force. And what that is, it's a group that we have, and we try to address issues and barriers that people living with diabetes are facing. And we like to meet quarterly, if not more. So the preliminary outcomes, a larger satisfaction of the clients. So we have a satisfaction survey that they fill out, and they feel better. They have a reduction of physical symptoms. And it's nice that people say they're thankful for us. And they, at first, sometimes they're like, oh, quit bothering me. I deleted you on Facebook. I didn't want to listen to you, because they were mad and angry about it. But after we build up that relationship, then the thank yous. I've been called a stalker before, but that's okay, in a good way, right? Connections to podiatry, vision services, behavioral health, and dental. So we want to make sure that yearly our patients have their standards of care met, and their flu shots and things like that, just looking out for them. Another thing is alleviating the fear of judgment. We want to try to, when we do our diabetes education or appointments, we want to be able to facilitate and not just teach and preach. We help them to problem solve, plan, and try to prevent emergencies. In our DSME classes, diabetes self-management education classes, our patients do really well with that. We also have different freezer meal workshops and different educational and facilitating and goal setting appointments with them. So here we're going to talk about a patient that had really good success. This is Craig, and Craig has so graciously allowed us to share his story. So Craig, he likes to chef it up. He's the one that cooks everything, and finding ways to cook something that's a little bit more healthy was kind of what we were going for with Craig. He spends a great deal of time supporting our youth. He had family members, relatives that played a lot of basketball. Basketball is really big. We go to state quite often. So he's in the bleachers all the time. And what do they have in bleachers? They have not the healthiest of choices. So he really worked hard to try to change that around. And when we first talked to Craig, he said, I deleted you from Facebook. I was just mad. Quit posting healthy stuff all day. And he was mad at himself, he said. And he shared with us that he was in denial, he was angry, and he didn't want to deal with it at the time. He wasn't ready. Craig, since then, he started with an A1C of 12.7. Craig has just been phenomenal. He's blossomed. He's an advocate for himself, his health, and for our programs too. He does an amazing job at remembering his medication testing, and he actually just graduated last week from diabetes self-management class, and his A1C is now a 6.12. The next one is Scotty's story. So Scotty, he's one of my first patients that I ever had, and I remember meeting him. He wouldn't talk to me. He lives with autism, so he has to be able to trust people. And he just kind of stared there at me, and I was like, what am I going to do? I'm supposed to meet with him, and he doesn't want to meet with me. So little by little, we were able to build a relationship with Scotty, even if it was just walking. My job is that I'm allowed to be able to spend time with patients. So we would walk. First one was 2 blocks and 3 blocks, and we tried to get his steps in, and we would do squats, and we would do different exercises. I even would bring different kinds of food because he had a really hard time with foods. The textures and how it made him feel, he didn't care for. He only liked certain types of foods, and vegetables and fruits were not on that list. So we tried to introduce different things to him and to help him with that. So before, he would barely even come to our appointments. Now he comes to the appointments. He does a great job he was able to visit with behavioral health. He was able to attend our diabetes self-management classes in a group setting. He's done a freezer meal workshop, and his A1C started out as a 10.65. His current A1C is 6.98. And he does his lifestyle coaching. He just checks in too. And I think that's leaps and bounds from when he was before. I would text him, call him. I'm like, man, I can't get a hold of him. He doesn't even listen to me. And his mom would say, no, he reads your text, and he knows that you're trying to get a hold of him, and he appreciates it. So I would just send little inspirational things to him. And then before I knew it, he was sending me different inspirational videos and things from YouTube. So I was like, wow, at least I'm making some kind of progress. And then this is just a note that his mom wrote to me. It says, I think Scotty's story is so inspirational, and it absolutely is. It just tells about what we did for him and how he has really taken it upon himself to take the driver's seat in his health. Our preliminary outcomes, we had 48 patients, 43 Winnebago tribal members, 4 Omaha tribal members, and 1 other. 28 female, 18 male, and then ages 24 to 77. The average age was 53. 40 completed the pathways. And then that kind of breaks it down. And then 38 reduced their A1C. And I'm pretty proud of that because that was kind of a audacious and tedious task when we first got started. And we worked together, and there were times when I wanted to quit, but now that we've got it under our belt, we're good to go. So I always laugh about that because I think about, man, in the beginning, I just, I think I wasn't seeing the whole picture. And now now that we see these success stories, it's worth it. And all the hang up calls and all the missed appointments and that kind of thing, and working through the barriers is absolutely worth it. This is the next slide here is the CHR Contributions. So we get supplies from when they run out. We help them to learn how to fill their prescriptions. We have an automated system. We these are some things that people have written too, that they admire, that we have tribal members in these positions, and they are going out to the schools, and they're able to help in prevention. So then the younger people don't have to deal with it. You know, our average age is in the 50s of people that we're able to see. So, and I think that says a lot for our program and for CHRs, and that we're out in the community and we're not just taking people back and forth to appointments. We're helping them with what they need. This says my CHR helped me to be aware of what I was eating. Instead of eating a whole fry bread, just eat a half of one. And that's something that we like fried food. We like things that aren't as healthy. We are 20 miles from an actual grocery store, and winter gets bad, and it's hard to prepare things and to have things if you didn't know what's healthy. And my idea of healthy might be different from their idea of healthy, and just helping people to kind of bridge that gap and to problem solve and to make better choices. And you can just read through these. They're different ones. Pill boxes. We ordered different pill boxes for people, and that was a barrier. We used to give some out that were at the little tiny ones, and they said, I don't need a tiny one, I need a bigger one. So just meeting people where they are and actually asking them, what could we do to help you? What's something that would really help? Helping people with seeing how much, how what they're drinking also affects what's going on with their diabetes care. So our focus group reports, these are patients that were living with diabetes that we saw, and it's just talking about what they were able to tell us. And they're really nice comments, and it's really nice to see how patients see us, and it's encouraging. It says, this one really makes me laugh because I know who it's from. It said, overall, the level of support by the CHR led to visible change. This client had just graduated from the diabetes self-management class, and he would never show up for anything, and that is the honest to God truth. And I'm glad that he took that upon himself too, and was honest about it, and now he sees a change in himself. So it says CHRs and Pathways, the foundation, CHRs plus Pathways. Community health representatives, AKA community health workers, promoters, etc. They're found in all the world's cultures. Community members, kind of like whom others look for social support. It dates back to the inception of public health. Indian Health Services adopted the use of CHRs back in 1968. Now about 1,200 CHRs work with 560 federally recognized tribes in the United States. And then it just talks about promote healthy behaviors with CHWs, so community health workers, promoters, and this is, the next slide is very near and dear to my heart. So in 2015, we started this program, these guys started this for us, and I just want to read this to you guys. It says, I want to take a moment to recognize the trailblazers that originally took this project on in the early days when it was just an idea. In 2015, they saw a need in our community and worked with the state of Nebraska to make sure that our people would have this much needed program. And it's Matthew Pilcher, they've all passed away. Jim just passed away very recently. And then Judy was our PHN director. And she was the one that was kind of the spitfire just to get it all going. And lit a fire under all of us too, and we want to remember the legacy that they left us. In conclusion, I just want to say, Pinagigi, you have done good for me in Ho Chunk, and ask if you have any questions, comments, thoughts, or concerns.
Thank you so much, Angel and Jessie, for taking the time today to share your program with us. And like Angel said, I feel free to unmute yourself at this time if you have any questions, or if you feel more comfortable, you can type your questions in the chat box as well.
Or if you ever want to email us or give us a call and ask any questions, we're available for that too.
I am going to put an evaluation link in the chat box before jumping off. If everyone could please fill that out, it would help us out quite a bit. We will stay on for a little bit longer if anyone has any questions to ask. Also, please keep in mind that our next webinar will be on December 11th at 1 o'clock. So keep a lookout for that invitation and call-in information. And also keep a lookout for the follow-up email that we will be sending with the recorded webinar today. Like I said, we'll stay on the line for a little bit longer if anyone has any questions. Otherwise, thank you so much for joining us today, and have a good Wednesday.